Welcome to the deep dive. Our focus today is laser-guided for your board preparation. We are rapidly reviewing the high-yield, benign, non-pigmented skin lesions that you absolutely must master.
That's right. We're focusing on the critical associations, the diagnosis, and, the streamlined management you'll need for your FRCS exam.
Exactly. This is your shortcut.
And to organize it, we have to think about cellular origin. All these lesions, they derive from the constituents of the skin. So we're talking keratinocytes, melanocytes, neural tissue, and all the adnexal glands.
Hair, sebaceous, apocrine, eccrine.
All of them. Knowing the lineage really helps you build that differential.
Okay, let's unpack this with purpose. Before we get to the complex syndromes and the tricky histology, let's nail down the common lesions of epidermal origin, the ones we see every day.
Right.
So, rapid identification, definitive treatment. What are the key features and management for seborrheic keratosis, squamous papilloma, and viral warts?
Okay, starting with seborrheic keratosis, or SK, also known as basal cell papilloma. Clinically, you're looking for that classic sort of greasy, plaque-like lesion.
The stuck-on appearance.
Exactly. Looks like it's just been stuck on the skin, usually on the torso of elderly patients. The standard treatment for these is a simple curettage.
Simple curettage. So we're talking a simple shave, not a deep procedure. For office management, that's a key detail.
It's typically a very simple shaving or superficial procedure. You're almost always just under local, as the lesion is almost exclusively epidermal.
Okay. Next up, squamous papilloma.
Or acrocordan, which everyone just calls a skin tag. Extremely common, especially in, intertriginous areas. For these, the treatment is straightforward excision.
A quick snip and cautery.
Pretty much. And finally, the viral wart. It's caused, of course, by an epidermal infection with human papillomavirus, HPV.
And management.
It really depends on the size and location, but you have three main tools in the toolbox: cryotherapy, curettage, or laser ablation. The goal is just removing those virally infected cells.
That covers the common stuff. Now, let's get to the epidermal lesions that are absolutely critical for the exam, the pre-malignant spectrum. We need a perfect understanding of the connection between actinic keratosis, Bowen's disease, and frank SCC. So, how does actinic keratosis fit into that progression?
Actinic keratosis, or AK, is really the starting point in this spectrum. It presents as scaly, crusted areas on sun-exposed skin. You see it in older individuals with a lot of photo damage.
And we consider part of the continuum leading to SCC in situ.
Firmly, yes.
Okay, and for advising patients, we need the numbers. What are the key statistics to retain?
You need to know both sides of it. The risk of progression to invasive SCC is actually pretty low, around 0.1% per year.
Right.
But, and this is important, a significant percentage, maybe 15 to 25% per year, will spontaneously regress.
And treatments?
They're all aimed at destroying the abnormal keratinocytes. So you have cryotherapy, photodynamic therapy, or PDT, or topicals like imiquimod, diclofenac, or 5-FU.
So where does Bowen's disease sit in relation to AK?
Bowen's is essentially the next step up. It's best regarded, clinically and histologically, as SCC in situ. The cellular abnormalities are strictly limited to the epidermis. They have not breached that basement membrane.
And you see it as a solitary red, scaly patch, often on the legs?
That's the classic presentation, yes. Lower legs of elderly patients. And the malignancy risk is higher here. About 3 to 5% of Bowen's lesions will develop into invasive SCCs.
But since it's confined to the epidermis, the treatment options are pretty similar to AK, right?
Exactly. The management mirrors AK. You can use cryotherapy, curettage, surgical excision, or those same topicals, 5-FU, imiquimod, PDT. The choice really comes down to the size and location of the lesion.
Okay, speaking of complex surfaces, let's talk about a lesion that carries a massive acute risk, the keratin horn. This thing is a huge diagnostic challenge.
It is.
We need to know the numbers here. What is the breakdown of malignancy risk at the base, and why is that biopsy so essential?
The keratin horn is, it's a very striking lesion. It's this hard, protruding lump of cornified material, almost like a tiny horn. The reason it's so critical for a board review is that risk stratification at the base.
And the distribution is?
You must know this. 50% of the bases are benign. 30% are actinic keratosis, and a full 20% are already malignant, usually in SCC.
20%. That is huge.
It is. And this is why the management principle is non-negotiable. To definitively rule out that 20% malignancy risk, The biopsy must, without exception, be excisional and include the base of the horn.
So if you just shave off the horn itself, the biopsy is useless for the real pathology.
Completely non-diagnostic. You have to treat the potential in the base, not just the visible horn.
Right. So you're essentially treating all of them as high risk. A full thickness excision or a deep shave is the rule.
Precisely. Now, let's move to another key differential diagnosis that plagues everyone. Keratoacanthoma, or KA.
The great SCC mimic.
The great mimic. Some authorities still argue they are just well-differentiated SCCs. But what defines KA's unique course is its biology.
The speed of it.
The sheer speed of its evolution and then self-resolution. It's a benign epithelial tumor, pilosebaceous in origin, but it grows incredibly fast over weeks or months into a dome-shaped nodule with that central keratotic core.
So then it just disappears.
It spontaneously involutes, usually within 4 to 6 months, and it leaves behind a characteristic depressed scar. That rapid growth and self-healing is what sets it apart, despite the histology looking so much like SCC.
And for high-yield associations, we have to connect KA to 2 critical familial syndromes. If a patient shows up with multiple KAs, what red flags should go up?
Okay, the familial forms are absolutely key for the exam. First, there is Ferguson-Smith syndrome. This is autosomal dominant linked to chromosome 9.
And this gives you multiple self-healing epitheliomas that look and act just like KAs.
Identical. And the classic historical note is that the ancestry often traces back to a specific family in Western Scotland in the 18th century.
Fascinating detail. But is Ferguson-Smith the one we really need to worry about?
No. The much more concerning one, for systemic implications, is Muir-Torre syndrome, MTS.
Okay.
It's autosomal dominant in about 2/3 of cases. It's often associated with a germline mutation in a DNA mismatch repair gene, usually HMLH1 or HMSH2.
And the triad for Muir-Torre is?
It's one or more sebaceous neoplasms, like an adenoma or carcinoma or keratoacanthomas, PLUS, one or more visceral malignancies.
And those are typically GI or GU carcinomas.
Usually, yes, gastrointestinal or genitourinary. And this is a huge deal. If you miss that Muir-Torre link, you've missed a chance to save a life, not just cut out a skin lesion.
That is absolutely the level of association that separates specialists.
Okay.
Let's move into the dermis. Hair follicle lesions can be so tricky because they all seem to mimic basal cell carcinoma.
They really do, clinically and histologically.
So how do we differentiate trichoepithelioma, trichofolliculoma, and trichoblastoma from BCC?
Okay, so trichoepithelioma and trichoblastoma are 2 that are very commonly mistaken for BCC. Trichoepithelioma gives you those translucent, pinky-white nodules, often around the nose and mouth.
And trichoblastoma.
Usually a slow-growing solitary nodule on the head and neck. Both are notorious BCC mimics.
So the key differentiator must be in the third one, the trichofolliculoma.
Exactly. Trichofolliculoma, which can be a small nodule with a central pore, also looks like BCC under the microscope. But, and this is the key, unlike a BCC, it contains characteristic keratin-filled macrocysts.
That's the high-yield detail, spotting those cysts.
That's what separates the benign adnexal lesion from the malignancy.
That is gold for the exam. Now, connecting this to systemic disease, what specific dermal lesion is the absolute hallmark of Cowden's disease? And what are the malignancy risks we have to counsel on?
The diagnostic hallmark of Cowden's is multiple tricholemomas. These look like small, skin-colored warty papules, usually clustered on the face.
And Cowden's is the PTN tumor suppressor gene mutation.
Correct. It's an important autosomal dominant condition caused by that germline mutation in PTN.
And the risk profile that comes with that mutation is massive.
It is. It's characterized by multiple hamartomas all over the body and a very high lifetime risk of developing breast, endometrial, and thyroid carcinoma.
And the skin findings are the first clue.
Over 90% of patients have the mucocutaneous lesions. So yes, the skin is often the first and most obvious sign of this serious underlying predisposition to cancer.
Let's discuss sebaceous nevus of Jettison. Common lesion present from birth, but there's a real management controversy here.
Right. The debate is excision versus follow-up.
So what's a clinical course?
The sebaceous nevus is a type of hamartoma. It's there at birth, but it gets bigger and more raised during puberty because of hormonal stimulation. It causes a classic bald patch if it's on the scalp.
And the controversy is all about the risk of transformation.
Entirely. The risk of a secondary tumor transformation is quoted at around 15%.
And what kind of tumors are we talking about?
The vast majority are benign, things like SCP, trichoblastoma, or trichomoma. But less commonly, they can transform into malignant tumors like a BCC or an SCC.
So the debate is whether to prophylactically excise in childhood.
Exactly. Because most of the secondary tumors pop up in adulthood and are usually benign, many advocate for just clinical follow-up. But that 15% risk and the small chance of a BCC or SCC keeps the debate very much alive.
Okay, let's quickly wrap up the adnexal group with three others: pilometric soma, cylindroma, and syringoma. Key identifier for each.
Pilometric soma is a must-know. It presents as a solitary, rock-hard subcutaneous nodule, usually on the face or head and neck of children. Remember the CTNNB1 gene mutation? Treatment is excision.
Cylindroma.
Pink lesions, usually on the scalp. If they're large or multiple, they're famously called turban tumors.
And syringoma.
Small, skin-colored dermal papules, typically on the eyelid and chest of women, and a subtype is associated with Down syndrome.
Okay, moving to lesions from neural tissue: neurofibromas and neurilomomas. For the exam and for surgical planning, how do you distinguish them? Histologically, and more importantly, in relation to the parent nerve.
Histologically, it's about the cells. A neurofibroma arises from non-myelinating Schwann cells, and it incorporates other cell types, so it's heterogeneous and not encapsulated.
Whereas a neurulomoma is pure Schwann cells.
A neurulomoma or schwannoma is composed solely of myelinating Schwann cells. It's more homogeneous.
And that difference in composition leads to a huge surgical distinction.
Absolutely. It's the critical point. Neurulomomas are encapsulated. That means you can often cleanly separate them. You can shell them out from the parent nerve without permanent damage.
But neurofibromas infiltrate the nerve.
They're infiltrating, non-encapsulated, and you can't easily separate them. Excision is much riskier for nerve function. And remember the specific forms, like plexiform neurofibromas. Anytime you see multiple of either, you have to work up for neurofibromatosis.
Okay, let's transition to cysts. Epidermoid cysts are common, but dermoid cysts, especially central ones, carry a huge pre-op risk. What's the critical consideration for central dermoid cysts?
So the epidermoid cyst, the most common one we see, usually has an overlying punctum. The key teaching point is you have to excise the cyst with that punctum or it's going to recur.
Right. And the high-risk dermoids.
Dermoid cysts occur at sites of embryonic fusion. Now, the ones that are the real problem are the central dermoids, midline, forehead, nasal tip.
Right.
Because they develop along those fusion lines, they can have deep intracranial extensions or connections to the CNS.
Wait, so for any central dermoid in that spot, a quick office excision is strictly contraindicated. We should be getting a scan first.
Preoperative radiology, a CT or MRI, is strongly recommended. It's essentially non-negotiable for central dermoids. That risk of an intracranial connection is the single highest yield fact about managing these.
That is a critical safety step. And while we're on cysts and associations, let's briefly hit Gardner syndrome.
Gardner syndrome. It's a critical autosomal dominant condition. You have to remember the triad. First, familial polyposis coli, which has a 100% lifetime risk of malignancy.
100%.
100%. Second, multiple skin and soft tissue tumors, including lots of epidermoid cysts and desmoid tumors. And third, jaw osteomas. Again, the skin lesions are the red flag.
Finally, we have to talk about xanthelasma. So often seen as just a cosmetic issue, but it is anything but. What immediate workup must we recommend for a patient with xanthelasma?
Xanthelasma is that accumulation of lipid in the skin around the eyelids. Thin yellow plaques. But the clinical significance goes way beyond aesthetics. Patients with xanthelasmata have a measurably higher incidence of myocardial infarction, ischemic heart disease, and death.
That connection is startling. So, the workup.
The immediate non-negotiable step is that serum lipids must be checked. You cannot just treat this lesion without addressing the underlying metabolic risk.
And how many will have high cholesterol?
About 50% of these patients will have previously undiagnosed hypercholesterolemia. So you aren't just treating a plaque with excision or laser, you are potentially uncovering a life-threatening but treatable risk factor.
This deep dive really reinforces that mandate for plastic surgeons to look past the surface. For the boards, you have to know these subtle differentiations and the critical systemic associations. Muratori, Cowden's, Gardner, and the lipid check for xanthelasma.
Absolutely. Understanding why a lesion behaves the way it does and what that means for the patient's overall health, that is the highest level of mastery you need.
Which leads us to our final provocative thought for you to explore. Given the strong association between keratoacanthoma, Ferguson-Smith, and Muratori, the latter linking Ka-like lesions directly to GI and GU cancers, how might your surgical or histological process change if a patient presents with a history of recurrent gastrointestinal malignancy? How does that specific clinical history shift the debate about whether a KA is truly benign? Thinking through that will force you to integrate pathology and systemic risk management perfectly.